Hello, good morning, everyone. How are you? We're going to have the panel in English in order to not drive crazy our translators. By the way, one round of applause for the translators over there. They are usually in the back of the room. And their work is fundamental because everything that we say gets translated, and our, the medical education jargon or lingo is not something easy to translate. So my name is Melchor Sánchez Mendiola. I am a pediatrician and medical educator. I work at the National Autonomous University of Mexico, Faculty of Medicine, and it's a pleasure to moderate this panel in this morning. Our panel's title, Roles, Competencies, EPAs, Entrusted Professional Activities, or Professional Judgment, Making Progression Decisions Without Losing Trust. This is a very important topic because whatever happens, decisions have to be made. And after listening to Dr. Lingard's presentation, I wonder how based on evidence are our decisions for progression, but that's something that we will discuss in this hour. How do we decide if a learner, a medical student, or a recently graduated physician or a resident is ready to move forward? What guides those decisions, speaking of difficult conversations? Should we rely on competency-based frameworks or professional roles, EPAs, or high-stakes examinations, or ultimately expert judgment, individual or group judgment? And too often these are presented as competing options. Perhaps that's the wrong questions. Perhaps the real challenge is choosing not just the instrument, but the framework, the system, to have something that works in a defensible, fair, and trusted system. And today we're fortunate to have two international colleagues with us. Kim Lomis is to my left. Kim is the incoming president of the Josiah Macy Jr. Foundation of the United States, effective July 1. And she finishes serving as Vice President for Medical Education Innovation at the American Medical Association in the United States of America. She's a surgeon. So as surgeons, she is usually, as most surgeons are, I assume there are surgeons in the audience? Yes, don't raise your hands. And she's an internationally recognized leader in medical education. She has led work in competency-based medical education, assessment, education innovation, precision medical education, and the responsible use of artificial intelligence in medicine. She previously served as senior educational leadership at Vanderbilt University School of Medicine. Kim, thank you for joining us. A round of applause for Kim. And we also have Anurag Saxena. He's president-elect of the Royal College of Physicians and Surgeons of Canada. He gave the plenary conference in the opening day. And he's professor of pathology and laboratory medicine and associate dean in the postgraduate medical education at the University of Saskatchewan in Canada. He's an internationally respected leader in postgraduate medical education and accreditation, and his work focuses on competency-based training, leadership, and systems improvement. Anurag, thank you for being here. So our purpose in the next hour, I know that today we started late, so please bear with us a little bit. We will take a few minutes of the break. And our purpose is to compare some of these concepts and help all of you to live with some practical ideas that you can use in your own schools and hospitals. So the questions of how to make decisions is not merely conceptual. It has ethical, educational, and organizational facets. How do we make progression decisions without losing trust, and trust from learners, from faculty, from medical schools, and ultimately society? So they will provide some of their views on this from their US and Canadian perspective, and then we will hopefully have a dialogue with you in the discussion. So I will first invite Kim to offer an opening perspective of these issues. So Kim, I just want to point out that we have these human beings that for many reasons decide to devote their life to healthcare. And they go through a lot of hurdles from the admission to medical school, and then passing all the courses on medical school, graduate, and then find a place for residency, which is not a trivial issue, and then to private practice or institutional practice after they finish the residency, because most people want to do a specialty or some graduate studies. And there's a lot of discussions in Mexico about all this transition in these important facets of everyone's life. So Kim, some words about it.
Thank you, Melchor. Buenos dias. Thank you for having me. I think that what we heard earlier is an important thing for us to keep in mind, this notion of the collective. So in the United States, as you know, we have a very individualistic culture and orientation. But fundamentally, our role as medical educators and administrators is to foster the healthcare workforce that's needed by the collective community. But we have a tension there because we have, as you said, very dedicated, ambitious young people who have their own dreams and hopes about what their career and their lives could be. And we need to also meet the needs of the broader community. And so that leads to some complexity across our systems. So in the United States, as here and as in many other countries, we have a diversity of types of medical and other health profession training programs. We have institutions that are affiliated with large research universities that are very academic focused, high complexity care, and we have other schools that are focused on more local community needs. So trying to understand the competencies that each individual needs to be able to plug into various parts of those systems and fulfill different roles can be a challenge for us as educators, particularly early in the training process. What is the foundation that anyone needs regardless of the direction that they're going to go? But at the same time, each of those organizations themselves are part of a more complex system. They have standards to meet, and they have goals that their organization must meet. And they have different access to resources. So in some situations, the educational program has a very strong affiliation with a given hospital and can easily place their learners into fairly controlled environments. Whereas other organizations may rely on sending their students out to a variety of different institutions where they feel less and less control over what happens in their growth and development. Through all of that, we've just recently completed our annual match process. So in the United States, all of the graduates are eligible to participate in a match process. There are a few specialties that aren't directly involved, but we had over 38,000 positions filled in a single day through a very complex computer algorithm that's actually part of a Nobel Prize laureate. So at that moment, the career decisions for many people are made or over that week as people react to that. And then as of July 1st, all of those new people enter this workforce and become members of the teams that Lorelei was working with, thinking about. And so what can the receiving team expect of a graduate who's come from a very different institution? In the United States, maybe more than other cultures, our graduates are willing to go anywhere across the country, and so they could move into a system that's quite different from the one in which they were trained. So there's always a stagger there at that transition because the receiving program doesn't have a lot of meaningful information about that learner's true progress and their development over time. And so there's a lag until they figure that out collectively in seeing the person work for the first few months and then have to address if there are areas that need attention. Then you continue through residency training. Many will go on to fellowships to have even more specialization, and then go off into practice. And as you all are fully aware, the scaffolding gets pulled away, and as we get into practice, we get less and less information about our performance. No one's really watching us or guiding us. And so we're really thinking about, in the United States, how do we kindle master adaptive learners who are more positioned to take charge of their own competency development over time? And then how do you provide them meaningful information to enable them to do just that? So we do need to address the clinical learning environment. As I mentioned, I think most of our educators feel less control over that, clearly, than a classroom experience, a structured curriculum. But it is indeed that clinical learning environment in which the collective competence is developed and emerges. And so we need to have stronger connection between the educational system and the health system. And we were talking about that we don't really assess individual, we do assess at the level of the individual, but not so much at the collective. However, if you look from the health system's perspective and the work in quality and patient safety, they are looking at the collective outcomes. And so how do we better bridge as educators? How do we forge stronger relationships to connect with what's happening in the healthcare system and foster everyone's development in a more intentional way? So these frameworks are an attempt to do that, but sometimes they feel overly complicated. And then if we take one more step in the introductory comments to recognize the fact that our vision of what it means to be competent is radically challenged in this moment by the disruption of artificial intelligence. I am very optimistic about the opportunity for artificial intelligence to help us do our jobs better. Because we do know we don't have wonderful outcomes, we do have significant errors, there's room for us to seek that help. But we aren't doing it with enough attention to how it plays out, how individuals are interacting with these tools and providing sufficient training. Most of us in medicine are recruited for our capacity to hold a great deal of knowledge in our head. That is no longer the skill that's needed because that's in people's phone. And so how do we shift our professional identity to recognize what's truly important? It's our judgment, it's our relationships with the patients. And to Lorelai's point, our previous assessment focused on that knowledge very heavily, often to the exclusion of these other skill sets. And so there's an immediate need for us as educators to elevate these other domains and to show beyond just talking about the value of these, that we truly mean it and we're digging in and assessing. So we're working in the United States to try to create more consistency of the frameworks, so the similar language about the skills and assets are used during medical school, during residency training, and continuing through professional development. And I'm hopeful that that view from competency-based medical education will widen our perspectives of the individual's performance and how they're interacting with others.
Okay, Kim, thank you very much for that. Anurag, in Canada you are lucky to have a competency-based medical education throughout the whole spectrum of undergraduate residency program, continuous professional development. And you have also this competency by design model, which is useful as a framework for these phases of transition. So some thoughts about from Canada.
Thank you. Anytime we start talking about competency-based medical education, and we heard from Dr. Lingard, for me, the fundamental question is, you are training for what? What is the ultimate aim here? So I at least conceptualize that every physician, realizing that there are notions of collective competence, how we work together, but I'll restrict my comments to individual competence, is I see physicians delivering two things. One is, can you deliver safe healthcare? That's one. So we train you for that. And second is, are you actually becoming a physician we want you to be? So do you have the identity, the mindset, the mental model? How do you embody that? So to me, the two key words are safe care and professional identity. Those are the two things we train you for as an individual, so that then you can become part of the team and be involved in that. So with that idea in mind, in Canada, we did implement competency-based medical education. For family physicians, it's a slightly different model. For the Royal College specialties, it's called competence by design. And really, it followed the established principles and the collective wisdom across the world on how to do that. So Melchor, you're right. We did have a very deliberate attention to what are the outcome competencies for each specialty, right? And then we paid attention to what learning experiences you need to have, how we are going to provide that competency-focused instruction, and how are you going to make sure that your progression is sequenced through different stages? And then I bring to the most important component where we still are not 100%, is the concept of programmatic assessment, which really, the way I understand, is that is our assessment serving the three primary functions? Are the learners learning, and can we be sure of that? Second, is the quality assurance of the curriculum being maintained or not? And third, the decision-making around assessments, is it proper or not? So that is how I've understood, which means that you have to have multiple different assessment tools, different points, different people involved in that, and then we make decisions based on a comprehensive set of assessments that you have done. Now, I will say one more thing is that, so a single assessment is not more valid than the multiple daily feedbacks you provide to the learners so that they can learn, such that they can learn from that formative feedback on a daily basis, and none of them, unless it's a serious transgression of professionalism or safety care, only is helping you grow in the direction we want you to grow, which is safe care and be a professional. Which brings us to, how do we do that in Canada? So in general, we have got these things called competence committees, which actually make collective decisions at different points in time, definitely twice per year about each resident. And these competence committees are now comprised of people who have some training, probably need more, on how to do three things. One, how do you discuss a resident's assessment? Two, how do you make the decision? And three, do you have the explicit criteria for making those decisions, like progressing as expected, not progressing as expected, failure to progress, and are you moving faster, like accelerated progression? So that is the approach, Melchor, we have taken in Canada, but I can tell you that the diversity of competence committees in Canada, even in one single institution, is huge. There's a variability in how they make the decisions. There is some standardization, but we do like to believe that we rely on both quantitative data and qualitative data and collective wisdom of the people in the competence committee. The last thing I want to mention is very quickly is there's a huge room for improvement in trying to do these assessments, because it's fairly, to use Dr. Lingard's word, it's got both components of both complicatedness and complexity. So one example I want to give you is that many times we find that the data is not of good quality. So we don't have enough data, and then because we rely very heavily on narrative comments, the quality of narrative comments is not great to make appropriate decisions. There are other challenges too, but those are the main things. So I feel that we are moving in the right direction, but there's a huge road ahead of us. So thank you. Yeah.
Okay, thank you, Anurag. It's a very complex issue. No? Whenever I hear about complexity science and complex adaptive systems, I wonder, how can we choose the specific element of this very complex system to actually push things the way that we want to go and not expect emergent things to just happen because this is an adaptive complex system, so I do not have any input on how to influence this system. But I'm sure later you will talk a little bit about systems-based thinking, which I think it's a major part of this. So one of the problems is that, for example, in Mexico, we have the universities that develop the curriculums and the educational programs, etc. And we have the hospitals and the academic health centers where the students, the interns, and the residents actually study and work. And these are very separate universes. You see, the university is a little bit expecting the faculty from the hospital to give a grade. And we have this global phenomenon of grade inflation. Because medical students are very bright people, they are very intelligent, they study a lot, but they are very focused when they see the hurdles that they have to jump through, the loops that they have to jump through to actually get to the goal of graduating or enter residency or finishing. So my next question is, how do we see this problem as an overall system where we have this delegation responsibility to some external summative standardized MCQ exam, or just the individual faculty to give a passing grade to students or residents and make these life decisions for the students in order for them to progress? How can you visualize this system in order to get some order out of this chaos? Kim.
Well, I think it is useful to, I know we talked earlier about patient-centeredness, but it is useful to think about the learner's experience. So you mentioned hurdles, you mentioned how complex this is for us. But the learners have a hard time understanding what it is that we expect of them. And we express our values as a profession through the assessments that we choose for those high-stakes moments. And so if we put a great deal of emphasis on knowledge and written tests, that is telling the learners that, yes, we talk about communication skills, yes, we talk about teamwork, but really what we want you to do is go home and study for this test. So we have to remember that our assessment system is a projection to them of what it takes to advance into our profession. And we need to realign with what we think are our true values. I think we have tremendous opportunity now. These frameworks call out the other domains and do provide to the learner a description of what it is that they're striving for. These are dedicated, very talented people. If you set a goal for them, they will achieve it. And so we've at least described these other domains that would be of importance for them. But how do we better assess? And you talked about a very busy clinical environment, and this is the disconnect, that those who are sitting in an academic institution have this grand vision of all of these domains being evaluated by a supervising physician or other health professional who can provide feedback on a learner's performance in the clinical realm. But they ignore the fact that the people in that clinical realm are simultaneously caring for patients. If you think about any other industry, sports, the coach is not on the field with the team trying to play the game. The coach is at the sideline. And so we have to be pragmatic about what can the supervisors truly observe and how do we optimize their time so that they are dialed in and providing the right observation, the right bit of feedback. And so these frameworks need to be coupled with some pragmatism about what we can do in the real world. The idea of multiple small assessments is fantastic for this, but it is only an idea until we fuel it. And we have great opportunity now to fuel it with data and technology so that the individual supervisor could be pointed very quickly to what that learner needs in terms of feedback and assessment given their overall portfolio. So we do have a lot of opportunity now to leverage data and artificial intelligence tools. We can also complement the assessment process by providing information about performance that doesn't rely only on the direct observation of the supervisors. So I do think there's an opportunity here for us as we grapple with these frameworks to simultaneously grapple with our values as a profession and ensure that we are truly demonstrating to the learners what we want them to have as far as that identity.
Okay, Anurag?
So building on what you just said, Kim, I'd like to identify two opportunities in improving the assessments. I think that's what we are talking about. One from the learner's perspective and one from the faculty perspective. So in Canada, in competency-based medical education, we have these things called entrustable professional activities, the EPAs, which are the major tasks a physician is supposed to do for your particular specialty. But EPAs by themselves are not enough for us to know that you have now become an integrated whole physician, right? So the issue from the learner side is that they in general tend to focus on EPAs and they feel that if I have accomplished my EPAs, I am competent, which is not true. There are lots of other aspects to becoming a physician and becoming competent. So I think we need to work with our learners so that they can truly internalize that Competence is beyond EPAs. So that's one thing. From the faculty side of things, I was hoping that competency-based medical education will actually take away the hesitation and the fear of individual faculty members to document and critique the areas of improvement. Well, it has significantly changed, but not to the degree we were hoping. So even today, I was postgraduate dean for 14 years, we found that individual faculty members still have hesitation in that. They do not like to document. My suggestion is, anytime I've had some interactions with faculty members is, and again we had heard about changing the thinking, because we are wondering that, you know what, if I were to say this to the particular learner, they might feel bad, and I don't want to document that, somebody else will do that. There are multiple reasons for not documenting it. But faculty members need coaching on how to do that, but there's a fundamental problem of mindset. I would think that when physicians are treating patients, they truly care about the patient, and then their decisions are guided by that. How about telling our physicians that when you provide feedback to the learners, you are actually caring for future patients, patients you have not seen yet. So really it is a collective thing for all patients. I think if we were successful to some degree in convincing our physicians that you are providing care for patients you have not yet seen, by providing good feedback, I think that might help in changing some mindsets.
Okay, thank you so much. There are so many facets to this issue. I was thinking, I don't know, you saw the news recently that Harvard University actually put a limit on how many A's, the highest grades achievable in the educational system, in order to decrease a little bit the phenomenon of grade inflation. Because in medicine and basically in graduate medical education, in the residency programs, we have this phenomenon of failure to fail. I mean, it's very difficult. If you have these people that has gone through so many hurdles and loops in order to enter residency, and then they expect high grades because, I mean, they are bright people. And then when you punish them with, in Mexico, we have this scale from 0 to 10. So if you grade somebody a 7, it's like humiliating. How can you give me a 7? And then the solution for faculty is just to pass everybody with high grades so you do not make waves and you just navigate the system. So how do you suggest that we could approach this? Because the educational system requires us to give a grade, a number to an individual, and there is a arbitrary level for passing. In Mexico is 6. If you get below 6, you don't pass. You have above 6, you pass, which is, so everybody navigates the system, and this apparent criteria becomes normative because everybody strives to have the very high marks, which, as usual, the grade average becomes important for your CV, for your life documents, or to obtain scholarships, etc., and to enter competitive programs. So some thoughts about that, Kim?
I think it comes to our collective competence as assessors. So we have historically relied upon the professional judgment of supervisors to judge whether a learner is worthy. These new models push us to shift to a coaching mindset and distributed understanding of that learner's performance. So what I look for in the performance of a student as a surgeon should be different from what a pediatrician looks for in the performance of that learner, and that learner will equally benefit from our disparate views and suggestions for their growth and improvement. What we found at Vanderbilt University, where I was previously associate dean, when we implemented our competency-based process, and we had a very complex digital dashboard for individual learners, I had to take that to each division meeting of the faculty. So I went to over 30 different meetings to show them the dashboard, Because I do believe that individual assessors feel tremendous pressure that my one point of data could make or break this learner's career trajectory, and therefore I maybe didn't get exposed to them that much. So even if I saw something, I don't want to put that much weight on my opinion from this interaction for a half day in clinic. When you show them the dashboard, which hopefully, theoretically, and we'll come back to that theoretical, has many, many data points. At first, it looks sort of just a scatter plot. It's all over the place because it's different situations, different clinical settings, different patient complexity, different assessors' viewpoints. But over time, you see a tightening of those ratings. Regardless of all those factors, the learners is perceived as more consistent in their performance. And it's that tightening that is really the signal that they are achieving the desired competency. But what you can do when you show those dashboards is to help the individual assessor know, you know what, if you truly document an encounter in which you had some concerns, and it's down low in that scatter plot, and there's many other points, if you sit there by yourself, that data point drops away and becomes less relevant because the overarching trend is moving on. And so you cannot, as an individual, sabotage that learner's progression. But if you put your little data point there and you're joined by a few other individual data points there, again, rather than judging the learner as not worthy, what we now have is a signal of where the learner needs help. And so when we see that signal, part of the assessment must be coupled with an action to the benefit of the learner's competency development. We get the signal, we have a very clear view of what exactly they need coaching on, which is most frequently not knowledge. So we can put them in a situation where they don't need to be separated from their routine schedule, they don't need a special remediation plan, but they could have a coach who's watching them specifically for clinical communication skills and giving them some guidance so that they bounce back up into the trend. And so if we can start to think about how we each contribute to that pixelation, so we have multiple different biopsies that give us perspectives on the learner, and then to Anurag's point, the competency committee or the individual's coach can look at all that data with them as an active, engaged partner, and the learner can say, I see a signal here that I need to act upon. Can you help me get better here? So that would be the ideal.
Okay, thank you. Anurag?
So at the individual level, I think it's about faculty interacting with the residents and with one question, unless it's a significant professionalism concern or a safety concern, it is about how can we help you become better? So that's the fundamental question at the individual level, right? And it can be done daily, it should be done daily, focused on small things. At the competence committee, as Kim alluded, it really is about pattern recognition and how do we do that. So I'll give you two examples here. There are multiple ways to interact individually with residents. One of the things I have found very useful is relying on learners themselves, because it's supposed to be learner-centric. So many times, even I have used it. I will ask a learner, how do you think you did? And most of them have good insight, right? And then they will say, well, I did this, and you extract it out from them. That's the essence of coaching. And then we say, well, what would you like to do better next time? And then they will tell you that. And then you ask them, well, how do you think you will get to that place, and how can we work together? So I find giving this autonomy to the learners where they have a say in their own improvement goes a long way, but it requires supposition of insight, which is there for most people. Now, at the pattern recognition level for the competence committee, it is extremely important that the people who are making decisions, they are formally trained in how to look at the collective data and how they are going to make the decisions. So I'll give you one example, very short, Melchor, is two things. When the learners are not progressing, we use two criteria. One is called failure to progress, and the second one is called not progressing as expected. So these are two very different things. So not progressing as expected means, there may be some small little glitches here and there, and we believe that concerns are minor, and that with focused intervention, you will improve, right? So you can continue your training like that with some focused attention. Now, when we say failure to progress, we mean that the concerns are global, like across the board. We have significant concerns, and you need something more formal, like an enhanced learning plan or a remediation or probation. So that is how we approach both individual level and competence committee level deliberations.
Okay, thank you. I remember, I don't know how many people here saw this Sesame Street TV show when you were children, Plaza Sésamo in Spanish. I remember there was one episode where, I don't remember if it was Elmo that said, everybody has issues. And my children, everybody has issues, yes. I mean, everybody has issues. And everybody has biases. We are full of cognitive and socio-emotional biases. And when you mention data and the dashboard, in Mexico we have this huge problem of data quality and who should collect the data and how should be available to people that have the responsibility of assigning grades. When we have all these issues of privacy of data, the students and residents want to know, well, if my data are going to be public, for example, in delicate conditions like some sexual harassment accusation or something like that, that's on the dashboard. Who is going to be able to see that? How can we improve as systems the data collection in order for it to be fair and transparent and useful for the institution, the faculty, and the students themselves?
So I think we, as a medical education profession, are becoming more cognizant of the downstream impacts of small errors in our assessment process or bias. And so because of these high-stakes progression pathways that we've been talking about, a slight difference in a grade at one point in training has cascading effects in which the learner therefore does not qualify for a particular honor, makes it harder for them to get the residency position that they were hoping for, et cetera. And so what we're starting to acknowledge is that we've obviously all known that there's some degree of variance in the quality of data that we get, and there's some degree of error in our judgments. But because we have this normative process, that slight error can be very much amplified downstream. So part of our challenge is to really try to break from the mental model of that normative orientation, because this is what we do to our learners, right? They are interested people, talented, dedicated, really want to contribute. If you think in the US, at least, I can tell you that if a young person in middle school thinks that they might want to go to medical school, what happens to them? Does somebody take them out into the community to start interacting with patients and understand what different communities need? Oh, no. No, oh, you want to go to med school, you better get yourself into AP physics in high school so that you can get into the right college that can get you into, et cetera, et cetera, et cetera. So we shift this person who has an aspiration to serve people and their community, we force them to think about themselves and how to show how special they are. And so right from the beginning, we move away from the very professional identity that we say that we aspire to. So can we envision a future in which we can break that normative approach, put people into meaningful engagement as early as possible, and better integrate providing care, being engaged with patients and communities with the education process throughout, and hopefully using more criterion basis, be able to advance people. But I think a lot of that requires humility on our part as educators about what we can and cannot say about someone's performance. We only have glimpses, we have our frames, and so we need to be cautious in our striving for fairness.
Okay. Anurag, some thoughts?
So I'll add just one thought here briefly. You know, whenever we try to do these assessments for progression for residents, institutions have different considerations and priorities. Learners have slightly different considerations and priorities, and society has different. So they may not always be completely aligned, and we have to make sure that our assessment systems, what we are doing, are actually meeting most of the expectations and requirements of most of the people we are working with. I'll not use the word stakeholders because there's some concern around that word. So that's one thing I wanted to say, that programmatic assessment, to put those principles into concrete plans, is really a struggle for many institutions, and I think we should spend a lot of time in spending how that actually looks like. What does programmatic assessment mean at the institutional level? What does it mean at the program level, so that how we can make those decisions? Okay? And you're absolutely right that we have to be catching residents early on so that we can direct them and put them and nudge them on the path they need to go. Because you know that if the plane took off from Merida and I wanted to go back to Toronto, the 1 degree off from Merida takeoff will land me somewhere in London, not in Toronto.
Okay. We're running out of time, and in the interest of time, I have many more questions, but I would rather use the remaining time listening to you. So please, if somebody wants to ask a question or a comment, the mics I think are open. I cannot see them with this light. I feel like a deer under the headlights. So you can make the question in Spanish or English as you feel comfortable. So, adelante, I don't see who was first. You? Okay. Please identify yourself and ask your question. Trying to be brief, please.
I don't know the mic. Can you hear me?
Yes, we can.
Hussam Hamdi from Dubai. The issue of programmatic assessment, we have to look at the history, how it has started in the Netherlands by our friend Kees van der Vleuten, because programmatic assessment is different from program assessment. And everything is context and culture related. So to collect data at different points, and then quantitative and qualitative, and then a group take a decision about the progress of the students is very culturally related. And that's why it didn't work well in other cultures, because you cannot defend the decision in a way. But I think now with AI and artificial intelligence and the analytics related to that, we can perhaps collect large number of granular data, which perhaps will give it more validity and more value in taking such decisions. So what's your intake on that? Thank you.
Okay, so Kim?
Thank you for the comment. I think one of the challenges is that we've talked a lot about collecting data, and we don't emphasize enough what happens because of that data. We still position, to your point, the data points as a judgment of the learner's worth. And so if we can be more agile with using that data to help the learner advance, I call it the so what. And so rather than jumping straight to what the clinical competence committee judges, where does the learner fit in? How are they actively engaged in interpreting that data? And I think what we've done poorly is we've presented these as, in a very reductionist way, that EPAs you have to check off and get them, quote, done, totally misses the concept of entrustment. And are you really embodying the professionalism that's needed to care for patients over time? And so I think we're at a crossroads where everyone collectively has been learning, and we are trying to describe all these things, but from the learner's angle, it starts to just look like a checklist of these data points, and then that raises an immediate defensiveness about the data and its quality, et cetera. And so it's really couching it more back into, we want to use this data to help you be the best physician that you could possibly be, and create an organizational culture in which that feels real. And that's the part that's not quite there yet. We haven't addressed the culture upon which we're overlaying all these data points.
Would you like to add anything? That's okay. So, Doctora, por favor, please.
Kai Montiel, de la Universidad Xochicalco en Ensenada. I'll try to make my question in English. What about time? We have competency-based programs, and the time to achieve the competencies are settled. But many students achieve them first. They achieve them before the time. So, and some of them need more time. So what do you think about that?
Okay, so Anurag?
Yes. So at least in Canada, the time is viewed as a resource, and in general, we have landed in a place where we believe that the residency time allotted is not changing. For instance, anesthesiology still needs 5 years, neurosurgery needs 6 years, so that time has not changed. However, we have built-in mechanisms now to allow more time for certain people who need more time without calling it absolute failure. We struggle a little bit with what you're calling accelerated progression, meaning people who finish early on, especially given the residents' focus on EPAs. They think that all EPAs are ticked, so therefore I'm done, I can go out. So institutions in Canada have different approach as to, in addition to meeting all the competency requirements, what else we need to do before we let you get out and allow you to practice medicine independently. So accelerated progression is a somewhat contested field in Canada. Many institutions allow it, but many don't. And there are criteria at different institutions to do that.
Okay, there is an experiment happening in the US called promotion in place, because it is difficult for our structures to really accommodate time variability, especially for these advanced learners. And so in this program, a resident that has demonstrated competence is allowed more autonomy within that clinical system and can convert to functioning as an attending physician, still being supervised through that transition and able to bill for services, et cetera. And so this seems like a promising model. It was supported by the American Medical Association in an early pilot, and now it's actually being picked up across surgery. And so the American Board of Surgery is helping, collaborating with the ACGME to launch a broader pilot across multiple surgical programs, and we'll see how that goes. But rather than trying to break the system to change the time, it's thinking about how can we use the time with more purpose and intention.
Okay, Dr. Santos? I think.
Yes, thank you very much. Very, very nice reflections. At the end of the day, who evaluates the evaluators? I mean, there's obviously a lot of heterogeneity within an institution, let alone within the state, let alone within the whole country or the provinces in Canada. And I always have trouble, I think what you've stated is very clear at the local level. But then who's doing the evaluation? And how competent are they? And what kind of training? Sometimes, well, we need somebody to evaluate, you do it. But you don't take into account that the evaluator perhaps also needs special nurturing so that the evaluation itself has some meaning.
Okay, so should the folks guard the chicken coop, or how do you say? Well, who wants to start? Anurag?
So thank you for that question. We do struggle with that. One of the things we did at the University of Saskatchewan was, proactive training of the people who are going to be on competence committees, but then we would require all competence committees to send their minutes and their decisions to the postgraduate office, whereby a group of clinician educators will actually look at those minutes and see are the decision-making processes following what they're supposed to do. It is not strictly evaluation of the evaluators, but it is at least trying to confirm that the processes that have been put in place, they're actually working or not working.
And then if you want to get to the point of what I would call the frontline supervisor, the one who's checking the boxes and filling out forms, I think that we have an artificial belief in this notion that we could standardize their performance. And as I said earlier, I'm not sure that that's even valuable, that we should embrace the variance in what they see. And can we use new capabilities in data analytics and artificial intelligence to interpret across, so accept that variance but make some meaning out of it. That doesn't mean that it should be the Wild West. And I think one of the things that we have failed as leaders of education programs is to acknowledge the many competing demands that those frontline supervisors are under, as well as this social pressure to score so that we allow people through. And so I think it requires very deliberate outreach, not so much about their ability to assess, but to acknowledge the things that are distorting how they assess, and working with them to create a different vision so that they could perhaps have better data about what they should focus on in a moment that they have, and then how can they express something that's going to actually help the learner grow.
We just have a couple of minutes left, so we have to close. If anybody has any other questions, they can approach our panelists. But before we close, I would like to ask Kim and Anurag, what is one thing that institutions or faculty should stop doing, and one thing that we should start doing in order to have better progression decisions? Kim?
So this is a bit radical, but in light of artificial intelligence, I think we need to stop as educators focusing on content delivery. We pour a great deal of resources across the continuum into pushing information out. That old professorial approach is no longer the best way for learners to garner the information. If we were to redeploy all of that effort and spend more time directly observing learners, giving them better feedback, giving them more coaching about how to improve, I think we would make much more impact on competency growth over time.
Okay. Anurag, last comment?
Right, so if we had to choose what you should stop doing, I would say stop relying on one tool for assessment. Right? And what you should start doing, if I had limited resources, which we all have, we will invest in faculty development, training them how to provide feedback and how to document critique of performance.
Okay, thank you very much, both of you. I think that first we can agree that no single framework or instrument solves these progression decisions by itself. They are complex and very complicated decisions that have a profound effect on the students. And second, progression decisions require more than isolated scores. They require meaningful evidence over time, as you mentioned. And third, professional judgment remains indispensable. I mean, not just artificial intelligence, but us. But it requires to be structured, developed, and accountable. And we have to develop this assessment culture in order to have all the, assessment is a science by itself. So validity, reliability, etc. And we have this tension of quantitative assessment, qualitative assessment, etc., which is, it would require another panel by itself. Well, thank you very much for your time, and thank you, Kim and Anurag, for your
Thanks for having us.
So have a nice break.